maybe then move on to a very important strategy paper, which is Bruce Keogh's proposals in relation to 7-day services. Bruce.
Thank you, Chairman. This paper, I think, provides a fantastic opportunity for our NHS. Over the last 5 years, I think we've begun to understand what quality in healthcare means to a greater extent. And that understanding has been enshrined in the Health and Social Care Act as that any organisation that provides care should provide care that is safe, effective, and as positive an experience as possible. And during the course of setting up NHS England, we also thought about what a good healthcare system should deliver. And we came up with 5 things. It should stop you dying prematurely where it can. It should help you to live a better life if you have a long-term condition. It should look after you well if you need a short episode of care. It should treat you with decency and give you as positive an experience as possible. And finally, it should treat you safely. And what I mean by safely is that patients accept their disease has a risk, they accept that treatment has a risk, they make a value judgment on that. What they should never have to accept is that the way that we deliver our services will negatively impact on that risk. And what is clear to us is that the failure to provide effective 7-day services in our NHS adversely affects each and every one of those 5 areas. Now, there are, and I think the impact is most starkly noticed in weekend mortality, and there's been a lot of coverage on that, but it also affects other areas. But there are 2 other considerations. The first is that through a series of surveys from the General Medical Council, the BMA, some junior doctors groups, from work conducted by John Collins and Sir John Temple on behalf of Medical Education England, it's become clear that the junior doctors at the weekend are feeling terribly stressed and under-supported. And that has consequences for nursing staff and other clinical colleagues in the hospital. In addition, there is the whole debate about whether we use our estate properly. So at the weekends, operating theatres tend to be empty, outpatients, clinics echo, laboratory equipment goes unused, and meantime we're paying maintenance and other costs on that real estate and equipment. And within that context, the Academy of Medical Royal Colleges, Health Education England, the Royal College of Physicians, the Royal College of Surgeons, the media and patients groups have all called for us to address this issue. But one point that I'd really be keen to emphasize is this is not peculiar to our NHS. And I know this from my professional role in international organizations, but also from some analysis done as part of a research group that I'm part of, where we looked at 254 hospitals in the United States, representing 90% of the academic not-for-profit hospitals, so the higher-end hospitals there, where their mortality statistics at the weekend were exactly the same. So I put it to you that we shouldn't use this as a stick to beat the NHS with, but that we should see it as an opportunity for us to show national leadership for the NHS, and the NHS in turn to show international leadership in the way that that healthcare can be delivered and the issues which I've raised can be addressed around the world. And so what I seek to bring out of this is a sense of ambition for our NHS, and particularly professional ambition, which I see as one of the strongest drivers for improvement in clinical care. And I also put it to you that there is probably no other healthcare system in the Western world that is better equipped than ours as the largest semi-integrated healthcare system to address this problem. But it is a massive problem, and the issue is where to start. And in conjunction with the Royal Colleges and the British Medical Association, we felt that the right place to start was with urgent and emergency care, because that, in a sense, is perhaps where the highest risk lies. And as a result of that, in last year's planning guidance, I was asked to establish a forum to see how we could kickstart better 7-day services in the NHS. And the paper which is before you outlines the findings from that forum. The proposals are based on essentially 10 clinical standards. And when you boil those down, they relate to improved diagnostics, because the first thing you need to do with someone that's ill is make a diagnosis, and the second thing you need to do is to treat them. And with respect to the second, that requires senior decision makers both to interpret the diagnostic results and to institute the appropriate treatment. And there are some quite remarkable things in the clinical standards that we're proposing. The first is that it's become clear from a number of reviews, from Francis' review, from my own review of 14 hospitals with a high mortality, is that there is often a delay in detecting the deteriorating patient at the weekend. So we suggest that every organization should have all their emergency and urgent patients on an early warning system, that patients who are at high risk should be seen within 1 hour by a consultant, that patients who are admitted during what one might consider normal working hours of 8 to 8 should be seen within 6 hours by a consultant, but that at the very latest, everybody should be reviewed by a consultant within 14 hours. And we also expect that to be supported, where appropriate, by a review by a multi-professional team within 14 hours. If you turn to paragraph 22 of the paper on page 6, you will see the incentives that we believe should be put in place to ensure that this happens. The first is a graduated series of commitments in the contract to promote the uptake of these standards. The second is clear transparency about which standards individual hospitals are implementing and how fast. The third standard is around the use of the Better Care Fund, because one of the issues in improving 7-day services is how we free up space in the hospital to enable this to happen. And of course that requires a concerted effort really across the whole of the health and social care system to enable us to discharge patients from hospital at the weekend. And this, in my view, is a really important point, and a point where this is at significant risk. The next incentive is that we would like to formally approach the Care Quality Commission to ask that no hospital is given the equivalent of an outstanding or excellent grade by the Chief Inspector of Hospitals unless these standards are being implemented. We also have agreement from Health Education England that they will not contract with hospitals that fail to implement these standards. And this is another really important point, because if we fail to supervise our junior doctors properly at the weekend and to support them, not only do patients suffer, but the training of the next generation of doctors for our NHS suffers. So there are long-term consequences in this. There are one or two other imponderables, if you like. The first is that the consultant's contract is under negotiation at the moment, and there are two specific things in that which will be under consideration. The first is there is a clause in the contract which says that organizations can't force consultants to work at the weekend. And the second issue under consideration is how to extend the plain time that applies to consultants. In other words, how long people have to work before overtime payments kick in. In addition to this, support will come from NHS improving quality. This will be part of their core business, promoting and helping organizations move in this direction over the course of the next 3 years. We've identified and announced 13 early adopter sites, all of which are at different stages on the journey towards 7-day services. And we've also developed some diagnostic tools to help organizations work out where they are on this journey. So we've also started, particularly through the London area of NHS England to work with the Chief Inspector of Primary Care to develop a similar set of clinical standards for primary care, which we would hope to bring back in 2014-15, and that would inform our future strategy of how to also promote 7-day services in primary care. I'd like to make the point, though, that this is not about every service in every hospital functioning 7 days a week. That is simply impractical. Nor is it about people working 7 days a week. This is about the provision and availability of essential services 7 days a week to local communities. An area of debate which has emerged out of all of this is, well, how much is it going to cost? And that is a difficult issue to address. So we've started with urgent and emergency care, which is complementary to the review which I reported on earlier in this year. But it seems that one of the main issues in this is the availability of consultants to provide the additional cover. And Health Education England have indicated that as from this year up till 2020, we're expecting an additional 1,800 consultants a year to come out of the training systems. The HFMA, who are the, if you like, professional association of NHS finance directors, have looked at 8 hospitals, all at different points in this journey, to see if they could understand how much this was likely to cost. And in hospitals that have already made a bit of an investment and have moved some way in this direction, they seem to be able to show, at the very best, some cost savings, and at the worst, it's cost neutral. There are others who are further behind who will need to make some level of investment. But the end result is that they think that within those 8 hospitals, broadly speaking, this will, to implement these standards, will be somewhere between 1.5 and 2% of the annual running cost. But broader analysis across the NHS is more difficult, because any analysis will be based on historic models of care. So we have to take a bit of a jump in this analysis. So we think that the best way to proceed is use the first year, data gleaned from the first year of the contract, where organizations will have to put action plans in place to identify how they're going to move in the direction towards 7-day services, along with information coming back from the IQ adopter sites. We think we can use that to inform a more detailed analysis over the course of the coming months. Before I close, I think I would also like to thank the media, who often come in for a lot of criticism, for the role they've played in helping us to have a very constructive debate with the public, which I think has given us a very clear mandate to proceed with this endeavour. So I would like to commend to you the forum's recommendations that are in this paper, and also to seek the board's agreement for the forum to continue and to consider the broader issues of how we roll this out into, with greater effect, into primary and community care services. Thank you, Chairman.
Thank you, Bruce, for a very lucid exposition, and also for the paper. I think everybody around this table shares a sense of excitement about this. This is a game changer. I think it's an opportunity for the NHS once again to become a global leader in the way in which it conducts its business, and that's immensely important. But more important than that is, I think, the mortality data that you give us, and it's not just mortality, but it's also morbidity, much of which has appeared in the press in recent days, but the strong sense that this is both a professional and morally critical change for us to make. And in terms of the financing, it's clear that much more work needs to be undertaken. We do know of some hospitals who have advanced quite a long way down this road already with cost savings, or as you say, at least cost neutral. The issue is how well we are able to disseminate their experiences and have other hospitals come to follow suit. And I think the final part of it is one of the reasons I think it is very difficult to have any clarity about cost, is that this is wrapped up in everything else we're doing. It's wrapped up in everything else we've been talking about this morning in the planning guidance. It's wrapped up, as you've indicated, in relation to London and the future of primary care provision in London, which may then become a model for the rest of the country. So I think it's tremendously important for a board like this to have an aspiration, which is strongly clinically based, for which there is clear evidence, and then a challenge as to how we drive it out. Not, as you say, universally, but in a way which gives maximum advantage to patients for every pound that we invest in it. So let me please invite comments from colleagues around the table. Kieran.
It's excellent. I think it's morally indefensible not to do it, and it's brilliant to do it. It's the link to the community. If some of this depends on discharging people well, then the community needs to be able to receive people 7 days as well. So that knock-on implication, I think, is going to be important as well. So any thinking done on that?
We've started some thinking, but really probably only got as far as the Better Care Fund and its administration through the Health and Wellbeing Boards. But it's really important that money is used effectively for helping patients get out of hospital at the weekend and for providing support services for them when they get home.
Barbara, okay.
Just exactly, this is fantastic, Bruce, and I think whilst our early focus is on hospitals, I think we do need to be able to assure our patients that the sort of GP services that they get out of hours are equally safe. We're recognising that this is not about routine care out of hours, although being able to access routine care out of normal working hours is important for patients, but that's a different aspect. But at the same time, as we look to make sure that we've got 7-day safety in hospitals for urgent care, then I think we have to make sure that the services in primary care, GP out of hours in particular, is just as safe. If you are urgently ill in those hours, you will be just as safe as you would be if your GP surgery was open.
Bill?
Thank you. It's great stuff. Just want to make the connection with the strategy work we talked about earlier. So, in response to Kieran, really, of those 6 service models we've been talking about, 3 of them are very closely connected to our ability to look after people better and people to look after themselves better in the community. The active citizen empowered to care for themselves as far as possible. The expanded general practice, particularly looking at people with long-term conditions, supporting them in their own homes, and the integrated care models really aimed at helping with a whole set of complex needs to get the very best care, right from lifestyle advice through to being there with you if you have to be in hospital. And I think that those are the people in our communities who are in hospitals evenings and weekends. So making that connection to the 7-day service has been another driver for those sort of radical changes to care models. I think will be quite important for us.
Good. Thank you. Well, Bruce, you're inviting us to endorse the recommendations of the forum, and I think we all do that, and to agree on its continuing work with a broadened remit. And I think we're content to do that. And can we also record our thanks, I think, I'm so impressed by the way in which the clinical community has come in behind this, with of course, the assistance of the media, but I really am taken with the extent of support we've found across the country for this initiative, and I hope that will continue as we carry it through. Thank you very much. We move on now to item 14 on the agenda. Bill, it's your paper on complaints.
Thank you, Chairman. Complaints and customer contacts, interestingly, probably the place that we're closest to people we serve in many ways. So this is a daily stream of contact and information and advice we give out. You'll recall that when we set up, we had to make an estimate of the capacity we'd need, and in the first quarter we underestimate, I think, the impact really that NHS England would have as a focus for an awful lot of questioning from the public. So typically our customer centre gets a huge volume of traffic, which then we direct to the right place, or when it covers a whole number of services, we take the lead in trying to give a response. And that meant that we fell behind our standards in quarter one. So this is a report on quarter two, where I'm pleased to say I think we're providing a far better service, both in terms of the response times and getting through our complaints, the customer contacts, but also in the most important bit, which is what do the people who are using this service think about it. And you'll see the customer satisfaction and the would you recommend this service figures are looking much healthier. So I think I can give the board assurance that we've got a service that's working reasonably well. The areas covered, unsurprisingly, what's coming up is an awful lot about primary care, and that's because an awful lot of our business is primary care. It's been helpful, I think, to establish within area teams the capacity to do a lot of the work with complaints and contacts about primary care, because of course that's also where the management and support and development link is as well. So we're trying to close that gap a bit between analysis of what the issues are and ability to have a response. The last thing I'd say is we've still got a long way to go. So I think we've got ourselves, we've stabilised what's kind of a decent traditional service that perhaps the NHS has provided in the past. Our ambitions, particularly on the back of Francis and the Clwyd's Heart Review, are to be far better at using the intelligence, the information, the contacts from our customers, both to steer our strategic priorities, but also to take actions really much more swiftly than we have to date. And that is some way off, and that I think will be the next piece that the board will want to see from Jane and myself on the future of contacts and complaints.
Thank you. Yes, we will want to see that, but I think what you present us with in this report is an encouraging picture, particularly the overcoming of the legacy bulge and also the handling of complaints. I spent some time recently with the Lancashire area team's complaints people, and I was really quite taken about the variety of complaints, from those which are very difficult, alleged misdiagnosis of complex conditions, for example, to those which are at one level quite trivial but really matter to the complainant, and to which the complaints team first responsible will pick up the phone and talk to them. Let's find out where the gravamen of the complaint really lies and how we can help to sort it very quickly. So response rates are matters of hours or at most days in many of these cases. It's the more complex ones that take longer to resolve. Joe?
I also visited the Quarry House team recently, and I would just echo that. So I was, in terms of optimism for the future and what you just finished on there, Bill, I mean, what I was really impressed with was the professionalism and the enthusiasm of that team to not just clear the backlog, but to do it differently in the future. And a number of them have come into the NHS from other organisations, private sector and other bits of the public sector, and bring with them a different kind of mindset about handling complaints, which I think is really to be welcomed. But like you, Malcolm, I was impressed with the range of things they were dealing with. Some of the complaints they're dealing with are really complicated, very complex. You can see why they take a while to resolve.
When a complaints team trouble with enthusiasm.
Yeah.
Because they care about, it's a consumer attitude.
Absolutely.
That is
really
what really
impressive.
caught my imagination. Barbara?
I absolutely concur with those, but I think it is right that the board should note that the area teams were not initially, because of the way we're set up to do this. I certainly think we should commend them, supported by the regions, for the way they've stepped into the breach and made sure that our patients are getting their complaints handled swiftly and better. But I do think the board should recognise the cost pressure, because our instruction was, this is really important for patients, you must put in place the people who can support this year, but that puts an enormous cost pressure on our administrative budget for next year if we're going to continue to provide a good service.
Right, I'm going to move us on, if I may. Our final paper, Bruce, from you, on NHS improving quality.
Thank you very much, Chair. This is to seek the board's permission to conduct a consultation with staff. NHS IQ is the organisation responsible for helping us to improve quality. It was established on the 1st of April 2013 from 5 legacy bodies. It's now a very different organisation with 3 core functions, which are about improvement programs, improving capability in the system, and corporate affairs within its own organisation. But it's also inherited a significant delivery team, and some of the work from that is starting to reach completion. Many of the people who transferred over as part of the delivery team have lived with a significant level of uncertainty about the future of their work and their own personal futures since before the inception of NHS IQ. So this paper really seeks the board's permission to consult on future structure and implications for individuals within that organisation. I don't know if Joe wants to add anything to that.
Only just to add that it's obviously a very similar situation to the PCS paper that we looked at last month. This is a lift and shift function that we brought in its entirety with a pledge to restructure it in this financial year. The only final thing I'd add is, because of turnover before it transferred to us and since, there are probably going to be more jobs in the new structure than there are people affected by change. So although those jobs might not match skill for skill, the redundancy numbers should be fairly low.
Good. I think, Bruce, we take the arguments in the paper. I'm particularly taken with the arguments about the new alignment with academic health science networks. I think this is immensely important, real opportunities. May I ask the board for approval of the paper and for the launch of the consultation?
Handle it well.
Yes.
That exhortation is ringing in your ears, Bruce.
It is, Chair.
Before I close the meeting, just two things. One, to report that the only other item of business I have is that the date of the next meeting is to be the 24th of January here at Southside. And in conclusion, just a few words of thanks. We've done 9 months almost as a wholly new organisation. I think our achievements during that time are commendable, but they're quite daunting in the sense that there's an enormous distance still to go. And today's discussions have highlighted that for us. But I think the board, and I hope the board would join me in expressing our thanks to our own staff, first of all, to 5,500 people who are working under completely new conditions and facing new and really difficult challenges. I think secondly also to the whole of the commissioning system, to our partners, our colleagues in the 211 CCGs across the country who are, I hope, working closely with us, I hope finding support from us, but also finding the new autonomy and the ability to do things in new ways that are well suited to the localities. But I have to say, above all, our thanks to the frontline staff of the NHS across the whole of England. 1 million patient contacts a day. It's an extraordinary organisation, and our responsibility, I think, is to ensure that we continue to drive improvement for the benefit of patients, but while understanding the pressures that this can bring on staff. We've heard the description today of the winter pressures, but there are pressures at all times of the year. With the leadership of our clinicians, of Jane and Bruce, I think it's possible for frontline clinical staff to see that there is a fundamental professionalism and purpose in all that they do, and that the responsibility to patients overrides everything else that we talk about around this table. So I hope the board would join me in expressing our grateful thanks to everybody in the NHS for all that they do for the benefit of patients.
Absolutely.
And with that, I declare the meeting closed. Thank you.